Good evening. Welcome to this BOMSS webinar on this Wednesday evening. My name is Dimitri Pounaras and I'm a bariatric surgeon at North Bristol. I will start with a couple of brief announcements. In 2 weeks from today, we'll have the Journal Club, which will be led by the multidisciplinary team based in Dublin. That is on the 9th of November. And in 4 weeks from today, the 23rd of November, there will be another webinar, again sponsored by Apollo Endosurgery, which will be on endoscopic treatments of obesity. Thank you to Apollo Endosurgery for sponsoring this event. And it is a pleasure and a privilege to introduce to you Professor Barham Abu Dayyeh. He is leading the Mayo Clinic endoscopy team, and he has made contributions that are leading worldwide in the treatment of endoscopic modalities for obesity. He'll be talking to us today about exactly this, and I'm looking forward to the discussion. There will be some questions and answers later on, so please send us your questions. Barham, the floor is yours.
Hello, colleagues. Thank you for the kind introduction, and let's cut to the chase for the topic of the discussion. And let me just pull my slides and we'll go at it. All right, please give me a thumbs up if you see the slides. Excellent. All right, thank you for the kind introduction. It's always a pleasure to be interacting with colleagues in the UK. And today we're going to be talking about endoscopic bariatric and metabolic therapy with a specific focus on NAFLD. These are my disclosures for the purposes of this talk. So before we take a deep dive into the field of endobariatrics, especially as it relates to metabolic disease such as NAFLD, it's very important to highlight the unmet need and what we do not really understand about the pathophysiology, or what we understand and could apply about the pathophysiology of this disorder. The numbers of individuals inflicted by NAFLD is astonishing. And you could see, if you scan through the global map, you could average a third of the world population having the disorder of NAFLD, which very much mirror type 2 diabetes because they're more of the same. They share mechanistically a common pathway, and most patients who are suffering from NAFLD have insulin resistance or type 2 diabetes, or in their pathway to develop this disorder. Therefore, these are the twin epidemics of metabolic diseases, both type 2 diabetes and NAFLD. Again, we spend, at least in the US, we spend a lot on type 2 diabetes. 377 billion, yes, with a B, and these are the numbers from 2017. I'm sure now we're spending even more. But unfortunately, we don't have much to show for it because less than 50% of patients with type 2 diabetes have a hemoglobin A1C less than 7, despite all the modern pharmacotherapeutics and interventional options that we have to give our patients. This is clearly defined in this 2020 report from the CDC, which estimates the diabetes burden in the United States. And if you look at the ABC goals of type 2 diabetes, which is A1C less than 7, blood pressure less than 140/90, cholesterol less than 130, and a non-smoker status, only a dismal 19% of patients reach these goals, despite all the healthcare expenditure that we spend on the disease. That means that we're missing something, and what we're missing is treatment of excess adiposity, because we're managing downstream pathways after the disease developed, rather than treating the common denominator, which is dysfunctional excess adiposity. That's why, unless we address the excess adiposity question with interventions, we're going to still lack effective therapeutics for type 2 diabetes and NAFLD. And this is really highlighted in this review of the pathophysiology of metabolic diseases, especially as it pertains to NAFLD. And you could see The liver is an innocent bystander responding to what happens in the metabolic picture. And what happens in the metabolic pictures, there is a gut adipose tissue liver axis dysfunction. That means the gut gets inflamed. The fat adipose tissue and results also get inflamed. There's crosstalk that develops insulin resistance. This chronic inflammatory state plus the insulin resistant state drive glucose and extra fatty acids into the liver. And the liver is an organ that has not evolved to store fat, and now it does not know what to do with the fat. It puts fat in its parenchyma. The fat gets inflamed, and you develop progressive fibrotic disease of the liver that ends up with cirrhosis requiring transplantation. Notice that the liver is not the culprit here, is the metabolic dysfunctions, both in the gut and adipose tissue are the pathways. And currently, we are not addressing these effectively with the current therapeutic spectrums. To that end, this shows you the prevalence of NAFLD and NASH in type 2 diabetes. And you could see they're parallel. They're almost, if you superimpose them, they're a co-linear relationship. Type 2 diabetes is NASH or is NAFLD, and NAFLD is type 2 diabetes, in my opinion. And you could see the numbers support this suggestion. Now, when we look at therapeutic targets for the treatment of NAFLD, you could see the windows of opportunity and is treating the metabolic and inflammatory targets early on. When fat makes it to the liver, the fat gets inflamed, and then that's where it's an opportunity to decrease the inflammation and decrease the adipose tissue burden or excess adiposity, which results in resolution of fat from the liver and reverse this metabolic clock on the insult. Once fibrosis is ongoing, there's multiple agents that target the anti-fibrotic pathways. But again, when we get there, the cat is outside of the box, and reversing the course is a more challenging issue rather than treating the metabolic defects and the inflammation early in the pathophysiology of the disease. So what's the major therapeutic targets? The major therapeutic targets is decrease in adiposity, improve chronic inflammation, which both of these results to improvement in insulin resistance. And if insulin is not driving lipolysis and fatty acids in the liver processes the extra fat in it, and fat resolves, the insult resolves, the inflammation resolves, and fibrosis would regress with time. And that's what we're dealing with. Now, if you look at histological endpoints, whether it's NASH resolution or fibrosis improvement, and you look at the multi-drugs that are in the pipeline for the treatment of NAFLD or NASH and fibrosis, you could see that by far the dominant effective strategy to histologically remove the fat from the liver and resolve the steatohepatitis is weight loss more than 10%. And this is conclusive. That means the dominant strategy to treat this disorder is get to a weight loss of 10% or more. And the weight loss of 10% or more is not additive. That means if you get to 20%, it does not double your chances of resolving this disease. And we know this from this publication in gastroenterology. The biggest bang in the buck for resolution of NASH is a BMI loss between 5 to 10%. If you get more than 10%, you get an incremental benefit, but not a big jump. Therefore, if we're designing a strategy to effectively treat the disorder of NASH, it would be having something that reliably get us to 10% total body weight loss or more. The problem with lifestyle intervention is for NASH is that when they work, they work. That means when you get to a patient to lose 10% total body weight loss on lifestyle intervention, whether moderate or high intensity, and they successfully maintain that weight loss, you could see based on this big study published in gastroenterology that steatosis improve in all these patients right here, fibrosis regressed in the majority of these patients, and NASH resolve in 90% of the patients. And that's the 10% total body weight loss again. But the problem is only 1 in 10, only 10% of individuals subjected to high intensity lifestyle intervention reach the threshold of 10% total body weight loss. Therefore, we need surgery, we need endoscopy, we need medications to target weight loss in order to achieve this threshold in patients suffering from NAFLD. And that's how the spectrum of care should be. It should be a continuum of care. You're stratified where you enter the continuum based on the severity of the disorder, and you keep moving. This is a chronic disease as long as you're putting the disease in remission. Therefore, I think the cornerstone is behavior and lifestyle. Building on that is medication. Building on that is endoscopy and then surgery. Different patients will gravitate to a particular intervention. Therefore, it's important for this spectrum of care to be fluid in order to increase access for effective therapeutics, because we know just telling our patients, go lose weight by yourself, is not a valid strategy in 2022 because it simply does not work. There is a huge unmet need and for access for effective therapeutics. Right now, 1% of patients who qualify for surgery get surgery or bariatric surgery, and even less than 1% who qualify for medication gets medication. Therefore, endoscopy or bariatric endoscopy hopefully will augment that spectrum of care to increase access for patients, because endoscopy is uniquely situated to offer the following value added for patients. Patients and providers and insurers are always looking for what's the value proposition, what's the value added. And with bariatric endoscopy, the value added is organ sparing. You don't lose the organ in a chronic disease model. They're safe and effective. They have no long-term consequences on health. So there's no long-term micronutrient deficiencies. There's no long-term worsening as far as we know in chronic diseases like reflux. Therefore, they have minimal long-term consequences to health. And more importantly, the intervention that works is the intervention that the patient could follow. So they are minimally disruptive to the patient lifestyle. And that's important when we talk about the injectables. Having patients taking injectables to treat excess gastroplasty for their lifetime is a challenge because we know compliance and treatment fatigue and cost is an issue. And that's the fourth added value of these interventions. So let's talk about preclinical studies, and then we'll talk about the endoscopic therapies as it pertains to this talk. It's very important to highlight that, again, the science showing that this weight loss, regardless of how you get it, is important for fatty liver is pretty clear. This is a proof of concept paper published in eBiomedicine that looked at a balloon endobarrier or a balloon and a bypass liner concept compared to rodents subjected to a raw wide gastric bypass. If you look at the sham operated rodents compared to raw wide gastric bypass rodent compared to the sleeve balloon concept, you see a very interesting story. In the sham rodents, the liver was full of fat and the skeletal muscle was full of fat, as we discussed the pathophysiology. You give them a raw wide gastric bypass, fat resolves from the liver and resolves from the muscles right in the middle. You give them the sleeve balloon concept, fat also resolves from the liver and resolves from the muscle, as you show right here. So similar changes in their visceral fat content, in their insulin profiles, and in their glucose profile. But the important picture here, which is sometimes a picture is worth 1,000 words, is if you look at the radioactive labeled meal in these rodents, and you look at the sleeve balloon, you could see that the mechanism of action in this cohort is a delay in gastric emptying. This radioactive meal is sitting in the fundus cap, not moving, and there's very little at 120 minutes that made it to these small intestines. If you look at the raw wide gastric bypass cohort, you could see they have rapid gastric emptying. Nothing is sitting in the gastric pouch. All of it have emptied to the small intestines very early at 5 minutes and at 120 minutes. And this is the sham. So despite this divergent mechanism of action, the metabolic impact was quite similar between the two groups. And this is an important concept that we're going to repeat and hopefully we'll discuss also in the discussion. This was also replicated in humans, by the way. And this is a paper published in the New England Journal of Medicine that looked at individuals, 15 individuals that prospectively were allocated to Roux gastric bypass, and another 18 individuals or patients that were allocated to a very low caloric diet, almost artificial kind of situation. They forced the patient to lose the same weight as the Roux gastric bypass patients in this boot camp type of weight loss, which is not realistic in clinical setting, but they wanted to prove a concept in this trial. So they got both cohorts to lose 18% total body weight loss, and they did the gold standard hyperinsulinemic euglycemic pancreatic clamp to look at insulin resistance. And you could see 18% total body weight loss, whether it happened with diet alone or with the gastric bypass, resulted in identical improvement in insulin resistance. Then they took it further. They looked at glucose homeostasis, both glucose and insulin, identical improvement. They looked at beta cell function and visceral fat content, also identical improvement. So now I showed you a rodent model. I showed you a human proof of concept that for fatty liver and metabolic disease, getting this threshold of more than 10% total body weight loss is sufficient to have a dramatic improvement in the metabolic profile of these patients. Now, surgery is still the best way to reach significant and durable weight loss. And these are the multiple surgical options available. It's a gold standard treatment for NAFLD as well. But as I stated earlier, access to surgery is limited, and penetrance of surgery is limited. And now we want to try to expand the horizon in order to increase this access, hopefully from 1 to maybe 10% with the introductions of drugs and with the introduction of endoscopic therapies that could effectively reach these weight loss thresholds. So when we talk about the endobariatrics treatment, we could divide them in those that target the stomach, and most of these work by targeting normal human appetite, both gastric accommodation, gastric emptying, and some of them work on ghrelin as well. So gastric intervention from an endoscopy perspective work on appetite pathways governed by gastric accommodation and gastric emptying. Then we have proximal small intestinal devices that work on insulin resistance, and distal devices that work on the microbiome and bile acid circulation. For the purposes of time today, we're going to focus on the gastric interventions because these are the most mature as far as the field of endoscopic bariatric and metabolic therapies. So let's talk about the clinical studies. We'll start with the intragastric balloon. Again, the intragastric balloon is a technically easy procedure. Do not confuse it being technically easy from being a procedure that requires close follow-up with the patients, because you're putting a foreign body in their stomach. Follow-up is crucial for the safe introduction of this into clinical setting, but the procedure itself is technically pretty straightforward. Anybody who knows how to put a nasogastric tube and do diagnostic endoscopy could be able to put the balloon therapies. Now, balloon, as far as NAFLD, works in both weight-dependent pathways, reaching this threshold of 10% total body weight loss, but also it has weight-independent pathways that we'll discuss in a bit. But let's look at the weight-dependent pathways as far as the intragastric balloon. And you could see this is a summary of the world literature before the randomized US trials. And you could see balloons have been in circulation for years. And when you look at total body weight loss at 6 months, where the old balloons were removed, now the balloons could stay in for a year. You could see it's about 13% total body weight loss. Again, reach this significant threshold of 10%. And when you look at 12 months, which is 6 months after balloon removal, patients who are in a multidisciplinary program do maintain a significant portion of that weight loss. Now, there's been multiple randomized high-quality trials looking at intragastric balloon. And as a group of devices, the intragastric balloon reached 10% total body weight loss in the average patient, which is significantly more than what could be done with moderate or high-intensity lifestyle program alone, as shown in these studies. Now, for the patient, averages do not matter. They wanted to know, if you subject me, if I have fatty liver and you subject me to an intervention, what's my chances to get this 10% total body weight loss that would result in improvement in the condition of my liver? And I plotted it here. You could see, based on the literature that I could find, the chances of reaching 10% total body weight loss with a balloon is 60% versus the 10% I showed you earlier with moderate or high intensity lifestyle programs. Again, the impact of intragastric balloon on metabolic diseases such as metabolic syndrome and type 2 diabetes and fatty liver has been summarized in this meta-analysis. I would not hash these numbers again, but the message here is this 10% total body weight loss is enough to produce significant improvement in the metabolic profile of the patient. The gastric balloons, again, I said the intervention is technically simple. However, the balloon patients need to follow in a multidisciplinary program. In that setting, the intervention is very safe. The problems happen with the intragastric balloon if we start putting them and telling the patient bye-bye. That's where the problems could happen. But in the context as shown in these multiple randomized trial, post-FDA register studies, meta-analysis, in a high quality programs, the risk of adverse events with the balloons are acceptable, and the balloon is a safe intervention with these conditional recommendations. Now, I'm not going to spend too much here, but balloons also delay gastric emptying. The delay in gastric emptying decrease postprandial hyperglycemia. It decreased postprandial insulin levels, improve insulin sensitivity. That results in less de novo lipolysis and de novo lipogenesis. So there's less fat driven to the liver. So independent of the 10% total body weight loss, the fact that the balloon delays gastric emptying has an impact on fatty liver disease that goes beyond just weight loss. And we went out to try to prove this actually in this proof of concept prospective study. It's a proof of concept in that the N was small, but it was a very difficult study to do because it was rigorous study that looked at histological endpoints and ensured enrollment of patients with true steatohepatitis and early fibrosis. This study resulted in the FDA issuing a breakthrough indication for the intragastric balloon for NASH. But to summarize the study, we wanted to include patients who have true inflammation in the liver because of fat and early fibrosis. So we used MREs to select patients. Finally, we got the 21 patients with true early fibrosis, fat in the liver, and inflammation. We subjected them to an EUS-guided biopsy. NASH is a patchy disease, and you want to biopsy the right segment that you are evaluating. With EUS, we could target the same segments of the liver lobe before and after. So we biopsied all these patients. We subjected them to the intragastric balloon. And then at removal at 6 months, we repeated the biopsies, we repeated the MRI, and we repeated the metabolic profile of the patient. You could see we succeeded. All these patients had histologically NASH, so all of their NAS scores were above 2. Most of them were either diabetics or pre-diabetics, which goes with what I told you. Diabetes is NAFLD, and NAFLD is diabetes in one sense. And their average BMI in this study was at about 44. You could see with the 10%, the cohort with a BMI 44 reached about 12% total body weight loss. Their hemoglobin A1C significantly improved at 1.3 points. Their liver biochemical profile also improved, and the stiffness of the liver on MR elastography improved, percent fat fraction improved, and also visceral fat. When we looked at histological endpoint, which is NAS improvement or resolution, similar to what we saw before, 65% of the cohort had complete resolution of steatohepatitis. 80% had decreased by 2 points, which is the endpoints that the FDA uses to evaluate the therapeutic interventions for NAFLD. And 95% of patients had an average decrease of NASH activity score by 2.6 points. Now, jumping gear to talk about endoscopic sleeve gastroplasty. Now, the value of endoscopic sleeve gastroplasty is now we're trying to enhance the durability of the weight loss by adding this gastric remodeling concept and enhance the magnitude of the weight loss. So we're operating close to the field of bariatric surgery, close to the lab band right here in the spectrum, but hopefully with preserving the organ and all the other advantages that comes with an endoscopic approach to this intervention. So that's possible, obviously, with innovation that could allow us to do full thickness suturing in the stomach. And you could see this is in an animal model, but we wanted to show the full thickness construct that the overstitch from Apollo is enabled us to do. And you could see with high fidelity, you could have serosal imbrication and full thickness suturing, despite this being a porcine model. And we know that porcine models have much thicker stomachs than humans. So the device is capable of doing full thickness suturing, and now we use it to do the endoscopic sleeve gastroplasty procedure, which does two things. It shortens the longitudinal length of the stomach. 1, 2, it tubularizes the greater curvature of the stomach, leaving a small pouch in the fundus. I would refer you to a publication in Gut about how this impacts human appetite, but the story in a nutshell: you eat your food, the food comes into the small pouch in the fundus, it quickly accommodates, so it stretches. That quick stretch of that cap in the fundus communicates through the vagal afferent to the central nervous system, tells the patient, you're full, terminate that meal. So now they terminate that meal with 100 calories instead of 800. Now this food is sitting in the fundus for a prolonged period of time, suppressing ghrelin. Food interacting with the fundus does suppress ghrelin, and because of the delayed gastric emptying, and the patient is not feeling hungry for a few hours. Then the food slowly empties through that tunnel into an intact antrum that's functioning and exits from the stomach. So you have both impact on satiety and satiation. So the patient could follow a low caloric diet and lose weight without feeling hungry or feeling satiated for a longer period of time. And that's how this procedure works. You all are familiar with the technicality of the procedure, but this is a quick 1-minute video to just show the sequence for those who are not very familiar. We start at the anterior wall of the stomach. We use the tissue helix in order to acquire full thickness bites of the gastric wall. We cross to the greater curvature of the stomach, then to the posterior wall. The procedure is based on this O-shaped sutures. The O-shaped sutures accordion the stomach, so it shortens it and tubularize the greater curvature. Now you see me here crossing to the greater curvature again from the posterior wall of the stomach. You can see the procedure is pretty straightforward. It's a pretty clean procedure, so there's not much blood loss during the procedure. And now we're cinching that configuration, and we're having this tubularized effect of the greater curvature. We repeat this for 4 sequences, and you're done with the procedure. Now, this procedure has been in clinical use for 10 or so years. Lots of studies published in the literature, but eventually we did a large randomized prospective multi-center trial published in the Lancet, and based on this evidence, the FDA issued market authorization for the ESG for patients with a BMI between 30 to 50, so wide indication as an adjunct to lifestyle intervention for the treatment of obesity. Again, this is a global view about all the published literature and the state of the evidence, but I wanted to highlight to you the most relevant evidence. This is a meta-analysis before the merit, and the meta-analysis shows a total body weight loss at 1 year of 17%. So you could see more weight loss than the balloons, and the weight loss is more durable because you could see maintenance of this 17% at the 18 to 24 months horizon. When you look at the merit trial published in the Lancet, it was a very representative trial. Again, this is a procedures for surgeons and gastroenterologists, and that's how we designed this trial. Half of the centers were gastroenterologists, half of the centers were bariatric surgeons. Half of them were in academic centers, half of them were in community. Some were expert, some have not done the procedure and trained to do the ESG during the merit trial. So the trial is very representative of real world, and even more so, it happened during COVID. So what you're seeing here is probably the worst case scenario for ESG. Despite that, the trial was very positive. The societal endpoints that they told us that we should meet is a excess body weight loss of 25% with a delta compared to a moderate intensity lifestyle of 15. That was the primary endpoint. We assessed the durability and the impact on metabolic diseases as secondary endpoints in this trial. It was a large trial of 208 patients. You could see the endpoint was 25% excess weight loss. We doubled that endpoint. We got to 49.2%. The delta was supposed to be more than 15%. We tripled that endpoint. The delta was 45% compared to moderate intensity lifestyle. Responders rate was 77%, reaching more than 25% excess weight loss, with those who are responded reaching total body weight loss of 16.3%. Second year of the trial was right smack in the middle of the pandemic, but you could see those who got the ESG in year one and crossed over, or got the lifestyle in year one and crossed over to ESG in year two, had identical weight loss to those who got it in year one without the pandemic. So, which tells you that there's an independent effect of the procedure. And those who got the procedure in year one, followed for year two, maintained most of their weight loss at year two. This was also associated with significant improvement in metabolic profile. Goes again with the earlier slides I showed you from that Nejam paper. We saw a very similar situation, right? When we compare those who got ESG versus standard of care, that means they had diabetes and their diabetes was managed based on standard of care with combination of medication and lifestyle and what have you. You could see those who got ESG had 93% improvement in their type 2 diabetes versus standard of care 44% worsened during the study period. A magnificent improvement in metabolic syndrome, 83% versus 38% worsened. Hypertension, similar story to, although lesser magnitude than metabolic syndrome and type 2 diabetes. When you look at biochemical profiles, HOMA-IR for insulin resistance improved significantly. Hemoglobin A1C improved significantly. Hepatic steatosis index improved significantly. Markers of inflammation improved significantly as well, which tells the story of this procedure. The procedure was very safe. Incidence of serious adverse events was 2%, including one case of a perigastric abscess that required endoscopic drainage, one case of upper GI bleeding that did not require transfusion, just required endoscopy with cauterization of an area that was oozing, and one case of maladaptive eating behavior and malnutrition that the PI at that site did not think that the patient is safe to continue with the weight loss. So they reversed her procedure endoscopically, not surgically. So we had no ICU admissions, no death, no surgical conversion during the MERIT study. Patients were very satisfied with their outcomes, and 80% would recommend the procedure to a friend or a family member. Now, post-MERIT, we have more data to highlight a similar concept. This comes from Dr. Aida Qahtani in Saudi Arabia. He did a propensity score matching of 3,000 individuals, big study, and subjected them for those with class 2 obesity, that means low BMI, 30 to 35, propensity score match to either laparoscopic sleeve gastrectomy, LSG versus ESG. And it was a non-inferiority trial. You could see that the weight loss was a little bit lower in this cohort than the LSG at 3 years, but within the non-inferiority margin. Improvement in comorbidities was similar in type 2 diabetes, dyslipidemia, and hypertension. Adverse events profile was similar. And importantly, the ESG did not prevent surgical conversion. So some patients will not do well with ESG and require graduation to surgical therapies. And that's another message that he was able to convert a bunch of patients to LSG with no issues or increased surgical risk. Now, Dr. Reem Sharaiha gave us a hint on further durability with this report published in CGH in 2020, showing durability of the response within the compound. That's the proviso, within a compound of a multidisciplinary program where you're using behaviors and some patients even using medication in order to maintain that weight loss for the long haul of 5 years. Dr. Mohit Bhandari and Galvana Nieto from India reported their experience with 612 patients. And now they reported their experience up to 4 years. Again, recurrent theme. They observed at about 20% total body weight loss at 1 year. Most of it was maintained at 4-year horizon, again, with the proviso that being done in a multidisciplinary program. They observed improvement in obstructive sleep apnea, dyslipidemia, hypertension, and type 2 diabetes. Similar story as I showed you in MERIT and earlier studies. And then this procedure is being done by bariatric surgery centers in the US. This is one of the high volume centers. This is a high quality community center. They reported their experience now with 404 consecutive ESG patients with the body mass index above 40. So they're now class 3 obesity. And you could see that in the confines of a high quality surgical program where there's significant support from behavior, nutrition, and physical activity, they even got more weight loss than we observed in these trials. They reached about 21% total body weight loss at 12 months. At 36 months, 20.3% total body weight loss, with again, significant improvement in hypertension, hyperlipidemia, and diabetes. So all this evidence led our societies, at least the GI societies, to recommend the use of these interventions as part of the management strategy for cardiovascular diseases, NAFLD, and type 2 diabetes. And the future, in my opinion, is going to be for NAFLD, that we're going to use these interventions to act on the metabolic inflammatory targets, because if we get them to lose the weight, the fat will resolve from the liver, and I hope I showed you evidence to that effect. Also, we're going to start seeing the combination where you have an endoscopic procedure like ESG to put the disease in remission. And over time, you could add medication in order to maintain remission now over the multi-year horizons in a cohort of patients that needs them. And this study showed that you took patients who were subjected to ESG. At the 1 month mark, they randomized them to either placebo or to semaglutide for 11 months after. You could see that the cohort randomized to ESG alone reached about 19% total body weight loss. The cohort with the combination reached to about 25.2%, not doubling the effect, but incremental benefit. In my opinion, the strategy would be let the ESG work for 2 years. Then if you want to start introducing medication, introduce them after that in order to have a health economic beneficial story. So going back to the slide, the future will be if you now superimpose ESG or gastric balloon or even bariatric surgery on this treatment algorithm for NAFLD, you could see that these could be the dominant strategy because they reach the 10% total body weight loss in the majority of patients pretty reliably, and that's the gold standard for the treatment of this disease. With that, I thank you for your kind attention, and we have a few more minutes for discussions and questions, so I will take down my slides and we'll open that forum for discussion.
Barham, thank you for a masterclass, really. Thoroughly enjoyed that, and I'm sure our audience has as well. I'll start with a question from the audience. There is a learning curve effect, and I was wondering if you saw that in terms of outcome during the trial.
Yeah, we absolutely saw that. I mean, there's going to be a publication from the MERIT about the learning curve effect. You could, and that's why. But the MERIT was designed to be a real world. We did not want to have experts doing this procedure and say, "Oh, look how good are these experts." We want to see how the real world. That's why when I told you it's the worst case scenario, it was the worst case scenario. It was pandemic, a generalizable trial. But again, you want to have clarity on what we're trying to answer, and we had to do it that way. But yes, there was a learning curve, and the rough numbers that I would quote people, again, for gastroenterologists and surgeons, and I believe me, I trained both gastroenterologists and surgeons, and they both could do this procedure very well. So the thing is, I think it's the first 10 procedures, they're not going to look good. Then procedure 10 to 20, you're going to start understanding the anatomic manipulation and the procedure becomes enjoyable. Procedure 20 to 50, you develop mastery. 50 to 100, you're very efficient to do the procedure in 35 to 40 minutes. That's the reality of these things. And we've seen that in Merit, and I see it in training people all over the world with this procedure.
And can I just clarify, this is for people who have basic diagnostic endoscopic skills or advanced therapeutic?
Basic endoscopic skills. Again, it's not advanced therapeutics. This is a procedure that if you know your anatomy and you know how to manipulate the gastroscope, you will learn this procedure. And the learning curve, by the way, the learning curve is very similar to therapeutic or non-therapeutic people because it's a novel procedure for both. So that's another important concept.
That's very important, very reassuring. And another question is that, is there any evidence for using ESG in a different context, and that is post-bariatric surgery hypoglycemia? It's asked by one of our endocrinology colleagues.
Yes, absolutely. We published in that, and I'm happy to share the presentation. We published with one of our colleagues from Germany, Dr. Christine Stier, who is very interested in that question. And Christine is very scientifically oriented. So she does not only settle for looking at questionnaires, she wanted to actually look at emptying time. So she did scintigraphy before and after the intervention. And yes, for patients with dumping, narrowing the outlet of the stomach to decrease the rate of emptying of the food bolus does help dumping significantly, and we use it for that indication all the time.
Brilliant. I think that there is some experience for that in the UK as well, from Dev Bansi. Another question is that, is this really metabolic endoscopic treatment? And that's a loaded question, but I guess the more specific question is there a range of BMI where you think is the sweet spot to actually do ESG in the range of treatment for obesity?
Well, I always like clarity, and I like to challenge some dogmas, right? When we say metabolic, if I based on what I showed you from the New England Journal paper, based on what I showed you in the effect on metabolic profile, which is inflammation, metabolic syndrome, biochemical markers of glucose tolerance and glucose resistance, you could say that by any stretch of imagination, all these procedures are metabolic because they're affecting the metabolic syndrome and the type 2 diabetes. Now, I think the question is there weight loss independent metabolic effect? And these are more elusive. And to be honest, I still do not fully understand them and comment on them, because the Digma challenge is that it's all mediated through weight loss. It's just bariatric surgery does the weight loss more efficient and more durable than any other interventions. We have not proven otherwise yet. So I would still answer is yes, it's metabolic, and the metabolic effect is mostly mediated through a durable and effective weight loss.
Fair enough. And it's also important to say that it took us a long time to understand the mechanism of bariatric surgery, so we need some time for this as well. Another question is regarding the quality of life measures, if you have any, between ESG and sleeve gastrectomy. Are you aware of any studies on that?
I am aware. There's been a match cohort from Johns Hopkins that matched them between BMI matched ESG versus LSG cohort, and looked at quality of life and looked at GERD questionnaires. And that's the other story. Again, is GERD improved in the ESG arm versus worsened in the LSG arm. So again, it doesn't mean that LSG was more effective in weight loss, for sure. ESG was less effective in weight loss. Safety profile was quite similar, but the GERD story panned out in favor of ESG compared to LSG in that study.
Barham, we will have to end. We could be here for a very long time. I'm very grateful. The BOMSS is very grateful for your time tonight, for this excellent talk and a brilliant discussion. A thank you again to you. A thank you to Apollo Endosurgery. Thank you to all of you who joined today. We'll see you all in a couple of weeks when the Dublin multidisciplinary team will be delivering a journal club. Thank you very much and good night.
My pleasure. Thank you. Thank you, colleagues. Good night.